Hello everyone, welcome to our RxTalks webinar brought to you by OmedaRx. We're happy to have you join us today, and we have our resident speakers, Dr. Steve Lamb and Rich Adams. My name is Allison Donahue and I'll be your moderator. I'll be keeping things running behind the scenes, and so I'll go over a few housekeeping items. Out of respect for our presenters, everyone is automatically muted. We received some questions on the registration process, and those will be covered throughout the presentation and in our question and answer session. We will capture additional questions throughout the presentation using the dialog box. Simply submit your questions and we will send them to the presenters to read and answer later in the presentation. Today's session will be recorded. So now for the fun part. Several of you answered our poll questions when you registered, and now it's time to reveal the answers. The first question is, what is the U.S. average opioid use per thousand in 2016? A few of you got this, and the correct answer was 695. The second question was, where does pain management rank in terms of condition costs for employers? Again, some of you got it, and it is first. The last question was, what is the biggest driver of the reduced productivity for employers? And again, a lot of you got this one. It is pain management. So thank you everyone for participating in those poll questions, and look for more opportunities to engage in future webinars. Now I'll give an introduction to our speakers today. Dr. Steve Lamb currently serves as our clinical pharmacist client manager for OmedaRx, where he has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. Prior to joining OmedaRx, Dr. Lamb was the resident pharmacist at a large health plan in Oregon, where he was exposed to a variety of roles, including formulary management, prior authorization, government programs, and specialty pharmacy, as well as clinical operations and administration. Rich Adams currently serves as the Director of Business Development at OmedaRx, where he oversees sales, account management, and product development. Before coming to OmedaRx, Rich held various sales leadership positions at industry-leading health companies. Rich's career work focuses on helping organizations navigate the new health economy. With that, I'm going to hand it off to Rich. Rich, take it away.
Well, thank you, Allison. Appreciate the introduction. It's nice to have you in the speaking role for this webinar, so welcome. Dr. Lamb, good to see you again. Thanks for having me again. Well, this is a very different conversation for us today. Typically, we're talking about market forces, microeconomic factors, good and bad actors in the marketplace, cost drivers, as well as clinical or operations best practices that drive value. However, today we're talking about a very challenging situation for the United States that may touch many of us on the call, the opioid epidemic. Today we'll cover the impact of the opioid epidemic, types of opioids and their appropriate uses, integrated opioid care management programs, and then what we can do as employee benefits professionals as we evaluate the different options that we have in terms of helping to solve the opioid management problem within the United States. So, as we step back, we see that opioids have been around for a very long time. The very first mention of heroin, an opioid derivative, is from Hippocrates, way back in 3400 BC. Hippocrates, the father of Western medicine, indicated that heroin was a narcotic and could be used as a sedative. It's pretty successful. In 1527, we see that heroin was used as pain reducer during the Inquisitions. Certainly, we all know about morphine being used in World War I and World War II, again, as a pain management tool. And then around 1914, we start to see the federal government, the United States, get involved with opiates. We start with the opioid or the Opium Exclusion Act, the Heroin Act of 1924. In 1938, the FDA is formed. In 1950, the FDA approves the first oxycodone, which is a derivative of heroin called Percodan. In 1970, the Controlled Substance Act comes in, and opioids fall under that guidance. In 1978, Vicodin is approved by the FDA. And in 1990 and 2000, the AMA and JCAHO established something called the Fifth Vital, which is basically pain management as a clinical discipline. So Dr. Lam, our first question is, with all of this attention from the federal government and from healthcare organizations, why do we have an epidemic today? What has changed? And what are some of the key characteristics that you see from your perspective that are driving the epidemic in the U.S.?
Thanks, Christian. I think that's a wonderful question. If we take a look at this slide here, it gives us a glimpse into why this issue is an epidemic. The different colored lines represent years, and the x-axis is the age groups, and the y-axis is the death per 100,000. Now, although this graph represents all poison-related death, which includes things like toxic household chemicals, etc., majority of the deaths represented here are really due to overdose of opioids or heroin. So prior to the 1990s, the rate of death due to poison was relatively low, at less than 5 per 100,000 across all age groups. Coming into 1990s is when we really start seeing some things change. The number of deaths began to rise up to 2014, where it shows tremendous growth in people aged between 20 and 50, which accounts for roughly 25 deaths per 100,000. Now, I think we have certain ideas on why this is, and as you mentioned, Rich, we saw pain become the fifth vital sign in the 90s. The American Medical Association was one of the first medical associations to adopt pain as the fifth vital sign, and physicians were really encouraged to assess pain symptoms just like they did with blood pressure and cholesterol. Thus, with more physicians beginning to pay attention to pain and treating pain, we saw a cultural shift, and which really paved way to where we are today. It is interesting to see that if you add up all the prescriptions within the last decade, Vicodin was actually the #1 prescribed drug in America. This approach has since changed, and the AMA has now dropped the fifth vital sign, but a lot of the damage has been done. So here are a couple more stats that really show why this is a problem. 91 Americans die every day from opioid overdose. The opioid drug overdose has now leapfrogged motor vehicle accidents as the #1 cause of accidental death. And the opioid epidemic within the U.S. costs about $78.5 billion. And this number accounts for costs related to healthcare, lost productivity, and the justice system. And 26 of that $78 billion is directly related to healthcare costs. And 90% of that $26 billion is covered and paid for by insurances and health employers. So that's a really big problem that's devastating our country as well as our local communities.
So from an epidemic standpoint, it's extremely expensive. $78.5 billion is a significant amount of money that's spent on opioids. The volume is also a key indicator of the epidemic. Volume of deaths, volume of overdoses, very, very significant challenges that we're facing as a country in terms of opioids.
Yes, absolutely.
So many of our participants on the webinar today work and live in the 4-state region: Oregon, Utah, Idaho, and Washington. And many are employee benefits professionals in the commercial sector. Often we see, I know I see in the press, either on TV or I read, about the opioid epidemic being limited or focused on states in the southeastern, southwestern parts of the United States and to a non-commercially insured population. Dr. Lam, how is the opioid epidemic impacting us in our 4-state region, and how is it impacting the commercially insured population?
Yeah, so there's actually a really significant impact in the 4-state region that we serve. If we look at this diagram, the total percentage of dispensed prescriptions for 1 year on the left-hand side is through retail chains, and we see that the national average is around 57%. Across the 4-state region, we're pretty much on par outside of Utah. Utah is about 72% right now, so there's a little more commercial utilization over there. And then if we look at the graph or the depiction on the far right, this is utilization per 1,000. And this includes all types of payers, including commercial, Medicare, and Medicaid. And it was significantly higher in 3 out of the 4 states, including Oregon, Idaho, and Utah. So the trend in the volume, overall volume in utilization within this 4-state region is increasing. And we actually took a look at our own books, and what we saw was there's actually an increase in the cost of care. They were 5 times more likely to cost more for patients who actually utilize opioid medication. So if we tie the volume and the cost together, this is a significant problem that we're facing within the 4-state region that we serve.
It's interesting. Dr. Lam, I know that you spend a lot of time talking with our customers and interacting with our consultants, our consultant partners and our broker partners, and then also interacting with the health professionals and then the employers as well. And as you look at individual employers and their drug utilization, are you seeing a similar dynamic? Are you seeing a significant amount of utilization of opioids at the client-specific level?
Oh, absolutely. If we look at some of the traditional drug spend, we see opioid typically, making it on the top 5. I mean, right now, diabetes is really driving a lot of that utilization in that category, but oftentimes we do still see opioid medications landing on there. So that is still a big problem for us, and that's something that we're tackling head on today. And there's a lot of levers that we can discuss a little bit later on how do we better manage these patients and these groups.
So we see the opioid epidemic from a national perspective, 78.5 billion. We see a dramatic increase in deaths and overdoses. When we look at the 4-state region, we see that we're above average in terms of commercial utilization, and utilization per thousand, we're above national averages there as well. And as we're looking at the client-specific level, you're seeing it in the utilization data there also. So it's definitely not focused on one part of the country or another. There's a challenge that we're facing here in the Pacific Northwest and the mountain states.
Yeah, this is a widespread epidemic everywhere.
So as we look at, let's back up for a second and let's talk about what is an opioid? How are they constructed? How are they similar to heroin? How are they different from heroin? Where does it actually come from, and how is it derived and structured from a chemical standpoint, and then from a medicine or a drug standpoint?
Sure, yeah. So our understanding of pain and how to treat pain has really evolved over time, but the use of opioids isn't really a new phenomenon. The use of opium really dates all the way back to 1600s when European physicians would use it, mix it with some sherry, and then give it to patients to relieve pain. As our understanding of pain is evolving, we're also getting a better idea of how it is sensed, how it is processed by the brain. So although much of modern science has evolved, the use of opioids still remain a key ingredient in how we treat pain. To kind of understand this a little bit more, we need to understand how opioids work in dulling the response to pain. So opioids really block the pain receptors in the body and prevent signals of pain from being transmitted to the brain. And they are very effective when they're used appropriately. The primary side effects, however, of blocking these receptors, that it can cause nausea, it can slow breathing, it can cause constipation, and produce some sort of euphoric effects, which is oftentimes the reason why people or patients abuse opioid medications. And when you look at this structure right here, heroin is structured very similarly to opium and to opioids. So it's no wonder why a lot of patients who are abusing opioid medications will turn to heroin. It's because they get the same effect in the high, and it also helps them manage their cravings a little bit better.
It's a very good explanation. Thanks for outlining where it comes from and how it's structured. I remember year and a half ago, I'm not sure when it was, when a tragic situation with Prince, and Prince ended up dying, and I was just fascinated to read that the medicine that he was on was something called a fentanyl lollipop. And that just seemed so foreign to me because I didn't realize that opioid or opioid derivatives could come in many different forms. So could you share with us or teach us a little bit about what are the different routes of administration, or what are the different forms that opioids can come in?
You're right, yeah, there's a ton of different forms, but when you look at opioids, they essentially all do the same thing, which is to block the sense of pain. And opioids can really be broken down into 2 separate categories, which include short-acting and then long-acting, which includes the medication that Prince was potentially abusing. The short-acting ones typically last a few hours compared to long-acting ones, such as the fentanyl patches, which may last a couple days, 3 days. So Short-acting ones we typically hear about are things like Vicodin, oxycodone, morphine sulfate immediate release, and even codeine. Some of the more common long-acting ones include the fentanyl that you mentioned, methadone, OxyContin, and then the extended release formulation of morphine. And they also come in a variety of different formulations such as patches, tablets, capsules, injections, oral solutions, lozenges, etc. And as you kind of alluded to earlier before with the Controlled Substance Act, these are all C2 medications. And now at one point, Vicodin was actually classified as a C3. But what we saw was that there was just a huge potential for abuse and misuse. And so what happened was the DEA essentially came in and said, we're going to reclassify this as a C2. And it was interesting to look at the stats because what happened at the time was due to the reclassification, we saw a significant drop in the amount of Vicodin that was used in the public. And so that's just a great example of how federal legislation can really impact the way that we utilize medications.
Lots of different routes of administration, lots of different forms that it takes. It sounds like a very complicated situation. I remember when I was a kid, if I'd fall off my bike or if I'd jam my hand playing basketball or something like that, my dad would say to me, grab my hand and squeeze as hard as you can, or are you bleeding? And that would be kind of the indication of how much pain I was in. But I hear you saying that pain is looked at much differently than that experience. So a little while ago, how is it viewed? How is pain viewed now from the medical community and from society as a whole? And how is that different from the past?
Right. So so previously in the past it was like, well, if you have some pain, let's just bite the bullet and deal with it, right? But now I think we're at a certain point where we're seeing pain recognized, and so physicians now clue in on pain a little bit more, and so they're going to address it a little bit differently. Now, where it's really evolved is how we approach that. So instead of kind of throwing a kitchen sink at it with any opioid, we go down to the level of acute versus chronic pain and utilization of short-acting versus long-acting opioids. And we also look at, well, because opioid is such a problem now, well, what are the other alternatives to treating pain? And we have a lot of those, which include pharmacological options such as your NSAIDs, which include ibuprofen or, naproxen. We also have Tylenol and acetaminophen, some local anesthetics such as lidocaine patches, and some non-pharmacological options such as acupuncture or PT or OT. So that understanding has really evolved over time, and how we strategize and how we approach pain is still evolving because it's something that's not very well understood, but we're putting more effort into understanding it.
I recall, I'm not sure when the transition happened, but going to the doctor with one of my kids and seeing on the wall, can you please describe your pain on a scale of 1 to 10? And it sounds like that's part of the evolution of how the United States looks at, and the medical community looks at pain and views it differently. It looks at it as a condition to treat as opposed to something to just tolerate.
Yeah, absolutely.
Now, Dr. Lamb, I've often heard that opioids are frequently misused. What levers and controls are in place from a health plan perspective to help promote, first, the appropriate use, and second, prevent misuse?
Sure. So we have a variety of different levers, for sure. So health plans and PBMs, you can really think about it, and they can be categorized into a variety of different categories, including how we touch the patient. So how we touch the patient or engage the patient proactively, how we do that concurrently while they're on therapy or seeking therapy, and then how to do that retrospectively, how to engage them after the fact. So first, let's just jump into how we do that proactively to really help prevent patients from getting addicted to opioids in the first place. And one of those levers that we can use is patient-specific education, so mailings that we can use to educate them on what their medication is for, how to appropriately use their medication, how to store the medication, what are the risks versus the benefits, and how to properly dispose their medications. And actually, this last point is very important because 75% of all opioid misuse really starts with people using medications that are obtained from a family or friend. So often this is because we have excess medications just laying around in the house, in our medication cabinets, and one of our family members or relatives or friends might gain access to that, which has been a huge contributing factor to this opioid epidemic. So this is something that's super easy, and we can just use a letter and mail it out on the first bill for a patient.
I know in previous webinars we've talked about the importance of health literacy and engagement, and it sounds like this is a very important component for helping to manage the opioid epidemic, is increasing the understanding of opioids themselves, what they're specifically for, what the treatment protocol is, and then once done with the protocol, how to dispose of the medicine.
Yeah, health literacy, I would say, is probably the most important part because if the patient understands it and we have that engagement piece, we're likely to get better health outcomes overall.
The other levers that you spoke about, there were two more. Did you want to say a little bit, a couple of other things about those pieces as well?
Yeah, great point. So the concurrent engagement piece for health plans and PBMs is we really rely on prior authorization as the primary tool to help drive appropriate therapy. While developing these policies, we want to make sure that we are in alignment with a lot of the standards of practice. So just last year, the Center of Disease Control and Prevention, which is the CDC, released their guidelines to help improve the way opioids are prescribed. Following our evidence-based approach here at Regents, we have adopted these guidelines and developed policies that align with those recommendations. So as we previously discussed, opioids can be categorized into acute and chronic, and there are short-acting and long-acting opioid treatments available. So as far as like a PA strategy for short-acting opioids, things that we can do are, restricting patients to a 7-day supply for new starts who are not cancer patients or are hospice-bound. We also can do things such as assess, what are the doses of opioids that the patients are requesting. Are they greater than a 90 morphine equivalent? And morphine equivalent is kind of the way that we standardize how strong a medication is, how strong an opioid medication is. And within the CDC guidelines, we actually see that they recommend for new starts to keep the dose less than 90 because anything greater than that has a significant potential to lead them to abuse the medication later on, and it might be more than what they need. From a long-acting perspective, long-acting opioid perspective, things might look a little bit more different. So things that you can deploy are, well, did a patient already try a short-acting opioid? So for those acute conditions where you might use it for dental-related pain or something that's less severe, short-acting might be appropriate. For patients who might need more long-acting therapy because they have severe pain due to lower back pain, etc., you want to really make sure that they've tried the appropriate alternatives, that they don't have a diagnosis of cancer pain or hospice pain. And other safety things that you can throw in there include, well, are they appropriately being screened by their doctor? Do we have a written agreement with that doctor and that patient on the goals of therapy because we want to be in alignment there? Do they have a signed pain contract to make sure that both the doctor and the patient are both held accountable for properly managing this pain? And are there things such as routine urine drug screens performed? So we ensure that drugs are not being illicitly used while we're also providing them with opioid medications. So those are some of the concurrent stuff that we have.
So I hear certainly there are very valid reasons for opioids to be used, whether it be dental pain or severe pain, surgery recovery, fibromyalgia, cancer, but there is certainly a very important component of education from the patient standpoint, and I would imagine from the provider and the physician standpoint as well. There is the evidence-based application of utilization management criteria, which is very important. And then you also mentioned something called a retro, which is a post-review of what's happened in a particular situation. Could you describe that a little bit?
Yeah, so actually interesting enough, if you look at the statistic right here, 3,600 people started misusing opioid medications for the first time today. So although we have all these levers in place to really drive appropriate utilization, appropriate follow-up, there's still that small sliver of potential where people will still continue to misuse. And so the question becomes, how do we track that? How do we monitor that? And with the retrospective engagement piece, what we do is we leverage our data analytics to identify members and prescribers who are overutilizing or overprescribing. And examples of this include looking at patients' doses. Are they too high? Does it exceed what is recommended by the guidelines, such as the 90 morphine equivalents? How many pharmacies are they getting the opioids from? Is it more than 4? how many prescribers are they getting the medications from? So do they have multiple doctors writing them prescriptions and then they're going to different pharmacies to get the medications filled? So that all kind of adds together the fact that the patient might be abusing the medications. So what this does is it helps us flag the patients who are overutilizing, and it puts safeguards in place.
Interventions almost, it sounds like.
Exactly.
With that retroactive review, I would imagine that a health plan or a PBM can intervene in a particular situation where an individual or a patient might be on the cusp of misusing.
Right. Yeah, so that intervention step is when we flag the patient, it looks like they might be overutilizing, we partner with their doctors, we partner with their primary physician to let them know that, hey, this is what we've found, and these are the potential steps for you to be able to intervene. Other things that we do is if that soft approach doesn't really work, well, then we can lock the patient into one pharmacy and one doctor to make sure that they're getting the appropriate utilization of the medication. Things that we're also seeing today are health plans can provide things such as provider report cards or dashboards to identify prescribers who are prescribing outside of the norm, so they're outliers. And these report cards essentially help them stack up against their peers and then find the appropriate opportunity for education from our medical directors.
It sounds like education, utilization management, and then a retrospective review with a lot of engagement from the PBM. Let's see if we can tie it all together. I know in the past, and you've taught me and you've spoken frequently about holistic and integrated care models. And in this particular instance, you've shared with me that integrated and holistic care is absolutely necessary for the successful management of opioids. Can you share a little bit more about what that really means?
Yeah, so I think it's important to note that successful opioid management isn't just reducing the overall amount of opioids a patient gets. There's just as much a behavioral and a psychosocial issue with this as there is a physical issue. So approach to care really needs to be holistic. And as we alluded to before, this is a multifaceted problem, so we need a multidimensional approach to care. If we look at this pinwheel, we saw and we discussed a lot of these different approaches, but one thing I really want to touch on is the legislative aspect. So we need to make sure that the policies that we develop from a health plan side and from a PBM side, that they really align with what our policymakers are doing as well. So one great example of how Regents has been able to do this is through the introduction of the Comprehensive Addiction and Recovery Act. This act really provided the vehicle for the government to provide grants to the state level to expand the access to prevention and education of opioids. And one purpose of this legislation, or one key purpose of this legislation, was to increase the patient access to medication-assisted therapy programs. So patients who are overutilizing medications, how do we get them down to the appropriate level? And this is what it really does with drugs like Suboxone or buprenorphine. Many health plans actually have prior authorizations on these drugs, which can create significant hurdles for patients who are trying to come off of opioids. And at Regents, we think that it's important for members to have access to these meds because if we put a PA on them, then there's a potential that we create significant hurdles which might deter them from actually getting care that they need.
Let me ask you a clarifying question. Today, in the holistic model, multidimensional, integrated care model, what would a patient experience in terms of pain management? And how do you see that evolving in the next couple of years from a delivery system standpoint as you look at this whole pinwheel?
Right, so I think although we have great intentions of being more collaborative, we still haven't quite reached that point where everybody's working with each other and coordinating that care. A lot of it is still fragmented, so a lot of the stuff that health plans are a lot of the strategies that health plans are putting in place, there might be some overlap with what's happening in the hospital or at the case management side of things. So I think if we peek into the future, that care coordination step needs to happen a lot more. We need to communicate with each other about the different strategies that we're deploying and how can we put the patient at the center and really make him the focus in how we approach care.
I don't think anybody on the phone would be surprised at what you're saying about there has been great steps forward in terms of coordinating care and integrating care, but there's still a tremendous amount of work to be done in terms of tying together the entire ecosystem. That makes complete sense, and is a very accurate description of where we see the healthcare industry as a whole, in fact. But as the key stakeholders on this phone, on the phone call, or public policy makers or insurance carriers or PBMs look at the universe or the ecosystem, what key indicators do they see or can they turn to determine whether or not we are moving forward in a positive way or not?
Yeah, so at the macro level, these indicators can be broken down into 3 categories, which include education, monitoring, and access. So you see that on the top part of the screen here. So underneath education, we have mandatory prescriber education. And this is really, are there laws in place that require physicians to take continuing ed classes each year to make sure they're up to date in their practice and how they treat pain? And then also underneath education is the opioid prescribing guidelines, which we've kind of talked about before. So has states developed or adopted their own guidelines to promote appropriate opioid use? Underneath monitoring, we have eliminate pill mills and physicians to delegate access to PDMP, which is the Prescription Drug Monitoring Program. And what this alludes to in the pill mill section is, are there regulations for pain clinics on how they might be overprescribing? And then for the PDMP piece is, well, first let's back up and discuss what PDMP is. This is really a database for pharmacists and for physicians to access to understand if a patient is doctor shopping, right? So every time a patient goes into the pharmacy to get a medication filled, a pharmacist is required by law to enter this information within the database.
Doctor shopping, let me ask you a clarifying question, Dr. Lamb. I've heard of pharmacy shopping before, meaning that I'm going to, wrong, right, or indifferent, I go to multiple pharmacies, right, and I get multiple prescriptions, and it's very challenging actually to look at a patient holistically when that occurs. What is doctor shopping? Is it similar? Am I going to multiple doctors, or what's actually happening?
Yeah, so that's really similar. So basically what they're doing is they're setting up appointments with different docs and then telling them, hey, I'm going through this issue with pain. Can you write me a prescription? So without the PDMP, you can see the issue here is there's not a lot of visibility. The doctor's not going to be able to know, well, did they already get a prescription elsewhere? But with the PDMP in place, now they have that visibility piece. They can actually lock in and say, hey, it looks like patient X just got a prescription from Dr. Joe over here. So probably I shouldn't be writing a prescription for them now.
Okay, that's good. Thank you for describing that to me.
Mm-hmm. And I think the last piece here is the access piece, so increasing access to naloxone. And naloxone is a drug that is typically used to help patients who have opioid overdose or heroin overdose. So we really want to increase the access to that. And then we also increase the access to opioid use disorder treatment, which we talked about earlier, was the MAT therapy with buprenorphine or with Suboxone. So the reason why we want to have more access to this is because we want to better manage and prevent patient-related death due to opioids and heroin.
Ties directly to the epidemic and what you were talking about earlier in terms of education and engagement, prescriber education, mandatory, prescribing guidelines, that makes perfect sense. Eliminating pill mills, the continuous generation of medicines that are unnecessary, creating a larger database so that providers and prescribers can share and understand a patient's condition and not overprescribe. And then when someone gets into a difficult situation, giving them access to medicines that are alternatives and or helping them overcome a disorder treatment that may have occurred, unintended consequences for opioids.
Yeah, one thing I'd actually like to add about the PDMP is that although this has great intentions, there are significant limitations to the program right now. And a lot of that has to do with the information is not available in real time. And the other big thing is it's not an integrated network or database. So across state lines, sometimes patients might be able to doctor shop in Oregon and Washington across the I-5 corridor, right? So until that starts to happen where we have a single system, it's going to be really hard to rely on the PDMP as a sole source to eliminate this doctor shopping issue. But we are seeing movement in the legislative front and at the state level to really start integrating or at least have laws available to allow physicians who might be practicing in Oregon to access the database in Washington.
Well, that makes sense. Yeah, cross-border is definitely absolutely critical in that situation. Now, you're in a unique position because you're able to see into each of the 4 states. How do you see Oregon, Washington, Utah, and Idaho doing in terms of addressing our national epidemic across these key indicators? Are we ahead of the curve? Are we behind the curve? Where do we sit?
Yeah, for the most part, I would say we are definitely behind the curve. So if you just look at the diagram at the bottom here, we in most categories are failing or lagging behind. Now, some of this data might be dated, and there are certain initiatives that have been put in place, but for the most part, we still aren't in that green category today. But we are definitely on the right track, and more effort needs to be devoted to addressing the problem, and we are definitely seeing that at the local state level amongst all stakeholders that are involved.
That's interesting. That's good to hear that we're making positive forward momentum on these issues. Now, we've talked about education, monitoring, and access. Now let's turn to the legislative or the public policy forum. And we know and we can see from this chart here that in the 4-state region, there are 11 bills currently in each of the state legislatures addressing the epidemic, the opioid epidemic. From your clinical perspective and professional opinion, what are 2 or 3 or 4 of the key pieces of legislation that are being proposed, and what will be their impact?
Yeah, so you're right, there are quite a few in this 2017 session right now, and some of the proposed bills will have a significant impact. So let's just look at a few of them. The first one I want to look at is we're seeing a lot of emphasis from states in putting limitations on the number of fills or the day supply that is being dispensed. So in the state of Oregon, Washington, and Utah, there are bills that are drafted right now that would mandate health plans, PBMs, to develop prescribing policies to limit the quantity to less than a 7-day supply. Now, when we were looking at, or when we were talking about earlier, the different levers that are available on that concurrent engagement, this is another example of how now our policies, and we're keeping pace with what's happening on the legislative front, are in alignment with each other, and we're coordinating and collaborating. Another thing I want to touch on is that the state of Utah and Washington are actually trying to pass laws that would mandate physicians to get appropriate training on how to treat with opioids. Now, a lot of us, we really rely on docs being able to treat pain appropriately, but what's been happening, or what we've been experiencing, is that a lot of doctors actually don't have the necessary training to be able to treat it appropriately or at the level that would be in accordance with what the guidelines are today. So there's definitely an education piece that we need to do a better job of. And so by passing some of these laws, we will see more appropriate therapy, and they will be more streamlined and coordinated with everybody else.
So to summarize, the important ones from your perspective are dealing with integrating communication between providers, PDMP, yeah. PDMP, sorry, thank you for clarifying. And then also education, helping providers and prescribers understand appropriate ways to administer opioids. Very critical. Well, as we do with each webinar, and before we turn to the audience for questions, we outlined three questions that can be used to evaluate what we've just presented. And so Dr. Lam will, in a second, evaluate or provide us with 3 broad questions that can be used to evaluate opioid management programs to determine their effectiveness. But before we talk about that, perhaps the most important piece that we can do from our perspective, from employee benefits professionals' perspective, is to become more aware ourselves. So as we interact with data regarding our clients or groups, we can understand what are the prescribing patterns, what are the utilization patterns, what are the types of medicines that are being used. We can be aware, we can be transparent about it, and we can be informed about the epidemic as it's impacting our particular realm of work.
Yeah, and we're actually seeing a lot of that now too, which is great, right? So health plans and PBMs are actually getting a seat at the table at a lot of these coalitions and work groups and collaboratives that are being formed at the state level. So we're having a significant impact not only in being attuned to what's happening there, but also being able to offer our services as well as our insight on how we would be able to collaboratively work together. So I think there's phenomenal work that's being done in these work groups, and it's great that we're involved with these because it's really been the genesis of forming some of these state-specific guidelines and some of these public awareness campaigns. So great work being done.
Outstanding. So guide us a little bit if you had 5 minutes to spend with someone, what would be the 3 or 4 critical questions that you would encourage us to ask as we evaluate opioid management programs, and why would these questions be important?
Yeah, so on the screen right here, we have 3 great ones. The first one is we need to provide examples of how opioid management programs are holistic. And why do we need it to be holistic? Well, it's because they will produce better outcomes. And we've seen that not only within opioids, but within other disease states as well, traditional disease as well as specialty medications that we've discussed previously. The second one is we need to be able to provide examples of how opioid management programs include evidence-based utilization of meds. So how does the program incorporate benchmarking data and provider reporting? And what we know is that evidence and data-driven solutions really improve the appropriate use of the meds and reduce the issues of fraud, waste, and abuse. And lastly, we have describe how the opioid management integrates with behavioral health and case management programs. And we know that integrated approaches, holistic approaches, really are appropriate, and they give the supportive care that is needed. So as we squeeze one end of the balloon, where we're restricting use, we also need to have the support that's available on the other side to ensure successful outcomes.
Nice. 3 great questions, 3 very relevant reasons as to why they're important. Well, Allison, we'll hand it back to you.
Okay, thank you. Well, at this time, we'll accept any audience questions, so feel free to type them in the dialog box. Give Rich and Steve a chance to take a drink of water. So we can see that people are busily typing. So just wait a moment and we'll get some of those answered. Okay.
Okay, so let's look at the first question that we have here from an audience member. The question reads, what is C2 classification? You mentioned Vicodin used to be a C3 and now it's a C2. What does that mean? I think that's a wonderful question, and I apologize for not addressing that earlier. But so underneath the Controlled Substance Act, the DEA really classifies medications based on its abuse potential. So it goes from C1, C2, C3, C4, etc. C2 medications are ones that typically have a higher abuse potential compared to C3s. And so what happened was when the medication Vicodin first came onto the market, we really thought, well, there's not a lot of abuse potential here, so let's just go ahead and classify it as a C3. But what we've learned is that, well, there is a significant abuse potential because it became the #1 prescribed opiate drug. So that is the reason why it was switched over to C2. So the next audience question that we have here is, what will it take to create more access to naloxone and opioid disorder treatments? Is that a benefit design level or an FDA approval process, etc.? Again, this is another great question. This really is twofold, and I think that most of the impact that we're going to be able to get is at the benefit design level. So we want to, for naloxone specifically, there are actually laws nowadays in the 4-state region specifically, and actually nationwide as well, where they can be dispensed by an actual pharmacist without a need for a prescription by the doctor. So you can do it through a standing order. And the goal of this, and the reason why we have legislation around this today, is because we know for a fact that naloxone is very effective in treating patients who have an opioid overdose or heroin overdose. So this is in effort to kind of layer that onto our benefit design. We just need to not have restrictions in place to limit this. So it looks like we have a couple more questions. So another question that we have here is, do you see opioids going to a pharmacy step program, having to fail NSAIDs before you can have an opioid? I think that's a great question. We know that NSAIDs or Tylenol are very effective in treating acute conditions, such as, if you have some pain in your hands due to a minor broken bone, you can use that effectively. Are we going to put a step therapy on to go through an NSAID or a Tylenol? Probably not, just because what we really want to focus on within our policy is those high-risk drugs, such as opioids. Now, there are risks of using NSAIDs and Tylenol renally within your kidneys as your liver as well. But the focus really should be on the opioids, and so we might have steps in place that will drive patients towards more cost-effective therapy, because we know across the entire class of medications, they all essentially do the same thing, and they all have essentially the same safety risk of using the meds. So what we can drill down to then is, well, which ones offer the better value? So you might see there a step therapy put in place. And we have one last question from the audience member is, what role do the family members play regarding the multidimensional care approach? And I would say this is a significant role that they would play. So it is important for us, as we look at this from a holistic standpoint, not to ignore those family members, because oftentimes they are that support network, right, that will be able to help the patients get the good outcomes. So the way that we can engage them is to make sure that the materials that we develop, how we outreach to the patients, and the policies that we develop reach them as well. So there will be things in place in the future that will allow us to do so.
Take your family members' medicines.
Absolutely.
Right. That was what I learned today.
Yep.
Well, thank you very much, Dr. Lamb. Lots of really good information. We covered a lot of territory. Very much appreciate you coming again and sharing with us your perspectives on your clinical perspectives and organizational perspectives, industry perspectives on opioids. Our next webinar is scheduled for April 13th. We will be talking about drug rebates, what you need to know. We're delighted to we'll have Dr. David Robertson with us, he's one of our clinical leaders from OmedaRx in partnership with Dr. Lamb to talk about rebates overall. Thanks very much, everyone. And Allison, hand it back to you.
All right, again, thank you everyone for joining, and look for the next invite.